Good morning, everyone. Welcome to another SWORP region webinar presentation. This one happens to be on medical delegation. We're determining whether we are big brother or best friend. Presenting today, we have Dr. Samir Mao, PGY4 in Emergency Medicine, also our EMS Fellow, and Dr. Adam Dukelow, our Local Medical Director. If you're new to webinar, you'll see a PowerPoint presentation and you'll hear a voiceover on the presentation. You'll also be able to interact either via chat box. So you'll see a control panel, and at the bottom of that chat box, you'll be able to type questions to us throughout the presentation. We'll also have the opportunity to open up a microphone if you happen to have one and take any live questions. So feel free to be involved throughout the presentation. If we do have a rather large number of questions, we will open it up and have a discussion throughout. Otherwise, we'll leave it to the end of the presentation. So without further ado, I'll turn it over to Dr. Mao and Dr. Dukelow, and here's your presentation on medical delegation.
Great, thank you very much, Stephanie, for the introduction. Good morning, everyone, or it's late afternoon my time, actually. I'm presenting from Cape Town, South Africa today. So welcome to another international broadcast, this time by your local-based hospital. We really appreciate your attendance this morning, and hopefully the technology stays reliable so I don't get kicked out of my own presentation and we can actually get through all our objectives, which you have up here on our slide right now. So these were the same as our handout that we had sent out earlier. Firstly, at the end of the presentation, hopefully everyone will be able to explain the concept of delegation in various settings, such as the emergency department, hospitals, nursing rooms, and for EMS, and also the role of the College of Physicians and Surgeons of Ontario in medical delegation. Next, describe the difference between online, offline, and direct or on-scene medical control. Thirdly, we're going to be discussing the meaning and implications of scope of practice, deactivation, and decertification. What do those really mean, and what are the differences between them? And then lastly, we're hoping that we can correctly apply the principles of medical delegation to a variety of different pre-hospital scenarios. Can you advance the slide, Steph? Thanks. So the outline of the talk, how we're going to meet those objectives, we're going to start off by going through the controlled acts as per the Regulated Health Professions Act, and we'll then go to medical delegation as per the College of Physicians and Surgeons of Ontario. Next, we'll talk about the scope of practice and the differences specifically in paramedicine and in nursing, as they tend to be the most similar. Next, physician on-scene requirements, and we'll go through some recent changes and direction from the Medical Advisory Committee. And lastly, deactivation and decertification. We'll be polling the audience for a handful of cases throughout the talk that we have kind of sprinkled through the presentation. We also have our chat room open, as Steph said, so please feel free to ask any questions live, and they'll get passed on to Adam and I to answer. So, time to start. A few cases to ponder at the beginning. Example case number 1. Steph? We have a 51-year-old male complaining of retrosternal chest pain and shortness of breath. This gentleman calls EMS for treatment and transport to hospital. He has no other medical history and is on no medications. An ACP crew arrives, administers oxygen, aspirin, nitroglycerin, and obtain an EKG and IV access. The patient is transported to the emergency department and is assigned a CTAS 2, and care is handed over to the nurse. The paramedic's care in this case is determined by which of the following: A, own practice, B, direct order from a physician, C, predetermined medical directive, or D, patient requested the specific therapy be completed. And we'll just give everyone a second to think about that.
Go ahead, Samir.
All right, so I can't see the poll results over here. What were the poll results? Oh, 100% for predetermined medical directive. I just saw them. All right, correct. So I'm glad everyone got that right, especially since research this year, we kept stressing the importance of the new medical directives. Hint, hint, nudge, nudge. So good job, everyone. Example case number 2, we have the same patient who has a return of his pain 6 days later, but this time decides to take himself to the emerge instead of calling an ambulance. The triage nurse performs the initial history and physical and assigns them to a C-Task 2 once again to an acute care area. And the nurse caring for this patient initiates an IV, oxygen, nitro, aspirin, and EKG, and draws cardiac lab work. So in this example, nursing care is determined by which of the following, and the options are the same: own practice, direct order from a physician, predetermined directive, or the patient requested the therapy. So we'll just give everyone a second again. Okay, so we have a mix of answers here. The majority of attendees chose direct order from a physician, and we have 1/3 of people who chose predetermined medical directive. The correct answer in this case is C, predetermined medical directive, and we'll be going through some of the specific medical directives in the emerge. So, some food for thought. We have the same patient with the exact same complaint who is being taken care of by two completely different healthcare providers, yet at the end of it receives identical therapy regardless of their mode of transport. So how or why is this possible? And this is something that we hope to provide a clear answer for you by the end of the presentation. So going on to example case number 3. Now this one unfortunately isn't a poll. There was 10 questions in the talk, and there's only a maximum of 8 that we could put in an official poll, so this is just something you guys could think about. We have a paramedics who are transporting a 19-year-old female patient to the hospital after she twisted her ankle at a basketball game and she's gone ambulatory. On arrival to the emergency department, the triage nurse sends the patient for an x-ray of her extremity before physician assessment. So nursing care in this case is determined by which of the following. We have the same answers: own practice, direct order from a physician, predetermined directive, or patient requested. And the answer in this case, once again, is C, predetermined medical directive. So example case number 4. Now we're going to switch scenarios outside the emergency room and go to a nursing home. So now we have a patient who's at Dearness Home, and the nurse on duty assesses one of her patients who's now slightly hypoxic compared to earlier, febrile at 38.7, and has been coughing since the morning. The nurse caring for this patient administers oxygen via a nasal cannula, gives Tylenol, and orders a chest x-ray before paging the on-call physician. So nursing care in this case is determined by which of the following. And once again, we have the same options: own practice, direct order, predetermined directive, or patient requested the therapy. And once again, even though the setting has changed, now we're in a nursing home, the answer to this question is still C, predetermined medical directive. So going on to the next slide, now we're going to be talking about medical delegation and controlled acts. What does this really mean? So, like I said, next slide please. The previous 4 cases all represented examples of medical delegation through predetermined medical directives. The paramedics and nurses in each case are performing diagnostic or therapeutic controlled health acts. So where did the term controlled health acts come from? Well, in 1991, the government of Ontario passed the Regulated Health Professions Act. And this act was made to ensure that the health professions are regulated and coordinated to the best of the public interest, and that appropriate standards of practice are developed and maintained, and that people in the population have access to these services provided by the health professionals of their choice. A regulated health professional is authorized to perform a portion, but none can do all of them, of very specific controlled acts that are appropriate for that specific profession scope of practice. And I'll be going through the controlled acts very shortly. Under the specific circumstances outlined by the Regulated Health Professions Act, nurses can perform very specific controlled acts independently, but these cases are rather rare, and the specific cases that we outlined in at the beginning of the talk were all through medical delegation, not through independent practice. So going on to the next slide, we have controlled acts. Like I just said, they were the controlled acts were outlined in the 1991 Regulated Health Professions Act. And this act sets out 14 of these controlled acts which may be only performed by certain regulated health professionals. This act also set out the powers of the Minister of Health, and it set up the Health Professions Advisory Committee and Appeal and Review Board. and sets out a list of which professions will be self-governed under this Act. Lastly, this Act also establishes the Health Professions Procedural Code, which is the set of obligations that governs the activity of all the regulated health professions. So what are these 14 controlled acts? We'll look at them right now. Here's the list of 14 on this next slide here. It used to be 13, but number 14 was just recently added, which is psychotherapy. So these are the 14 controlled acts. We have communicating a diagnosis, performing a procedure below the dermis, cornea, mucous membrane, or surface of the teeth, setting a fracture, moving joints of the spine, injecting or inhaling a substance, putting an instrument, hand, or finger beyond the external ear canal, beyond the larynx, beyond the nasal canal, urethra, for example. Next, applying a form of energy, prescribing drugs, eyeglasses, or hearing aids, managing labor and delivery, allergy testing, fitting a dental prosthesis, and lastly, psychotherapy. So like I said, although the Regulated Health Professions Act prohibits the performance of controlled acts by those not specifically authorized to perform them, it does not apply if the person doing the act is doing so to render first aid or temporary assistance in emergency. So the clearest example here would be a layperson applying an AED to a cardiac arrest patient in public. So they, even though they're not a regulated health profession, they're still cleared to perform this act in the case of an emergency. Now, some professions are authorized to perform some of the same acts, and that's just due to the overlap between some of the professions. But there is no profession that is allowed to perform all 14 of the controlled acts. If we go on to the next slide for physicians, physicians are allowed to perform 13 of the 14 regulated acts, everyone except for fitting a dental prosthesis. We're going to leave that to our dental friends. Going on to the next slide about nurses. Nurses are allowed to perform 3 of the 14 regulated acts, being performing a procedure below the dermis, so that would be something like putting in an IV, injecting or inhaling a substance, and lastly, putting an instrument, hand, or finger beyond the places I just mentioned before. So nurses can perform these 3 acts within their own scope of practice, but they usually need an order to do so. A registered nurse or a registered practical nurse may perform the procedure within the controlled acts authorized to nursing if it's ordered by a physician, dentist, midwife, or a nurse practitioner. So you can, for example, a nurse can't just put an IV into any patient who comes into the emergency room. There needs to be either a standing medical directive or an order from a physician. So now I'll pass the presentation over to Adam to go on to delegation of controlled acts.
Thanks, Samir. I'm going to take a couple seconds to explain why Samir is presenting from Cape Town, South Africa. It's not just a vacation that he's on. Samir's actually in Cape Town for the next 5 weeks learning about penetrating trauma. Fortunately, in southwestern Ontario, we don't have a ton of penetrating trauma, so our residents often go to other places to learn about both stab wounds and gunshot wounds. So over the next 5 weeks, you'll see literally hundreds of those types of cases so that when we have the occasional injury in downtown London or Windsor, that he is better capable to take care of them, assuming that he ends up practicing in one of those 2 places at the end of his residency. The other thing I wanted to briefly talk about before I get into the slides is the essence of this presentation is to help all of us understand what delegation actually means and where legislation or what the Ontario government dictates, where the rubber meets the road actually, and how this affects the practice of doctors, nurses, and paramedics. I've been an EMS physician now for 3 or 4 years and truly learned a lot in helping Samir create this presentation. And I think everyone in the office learned a lot creating this presentation. It begs the question is, do we spend enough time in medical school, in paramedic college, or in nursing college actually talking about the legislation? As boring as it can be, perhaps we should spend a little more time discussing what practically affects our practice on a daily basis. So now back to the actual formal slides from the presentation. Thank you for allowing me or listening to my interlude, so to speak. So the College of Physicians and Surgeons of Ontario regulates how Dr. Llewellyn, Dr. Bradford, and Dr. Eby and I delegate to the paramedics of Southwestern Ontario through policy number 8-10. It's been updated as recently as September 2010 and is actually going through a larger update currently, and Dr. Llewellyn recently met with some representatives from the college to discuss the effects of the new policy from the CPSO on delegation on paramedic practice. Within this policy, there are a number of tenets outlined that regulate how we delegate to you. The Ontario law through the Regulated Health Professions Act that Samir briefly talked about a few slides ago states that certain acts can only be performed by certain healthcare professions. This is to protect the public and ensure quality healthcare for everyone who is a citizen of Ontario. However, under appropriate circumstances, these acts can be delegated to others. The policy outlined by the CPSO outline what appropriate circumstances are and the necessary tenets to perform that delegation. So the principles of delegation, which go from no matter what type of healthcare professional you are that you must follow, is that the primary consideration should be the best interest of the patient. So why are we delegating? Is the physician cannot provide this care to the patient given the circumstances. So obviously the ambulances are not staffed by physicians, and there's way too many healthcare emergencies out there for the government to pay physicians to deal with all of them. So in that circumstance, we can delegate to paramedics to provide care that's needed in an emergency. There's two methods in which physicians delegate. One is direct orders or online medical control. I noticed that in the second poll that we did, a lot of you felt that it was a direct order from a physician to a nurse that allowed them to delegate that care. And in fact, that is often the case. So once a physician sees a patient in the emergency department and writes orders, then that is a direct delegation of a certain care that only a physician will be allowed to provide in other circumstances. It's specific to that patient at that time, and only after a doctor-patient relation has been established. It could be either verbal, written, or in person. So an example from the hospital would be if a nurse pages a resident on call about a patient who's developed a fever on the ward. The patient has lower abdominal pain and foul-smelling urine. The resident might ask the nurse to perform a urinalysis, a culture of that urine, and give some antibiotic and some Tylenol. That would qualify as direct medical orders or direct online medical control. Another example from the paramedic world would be there's a mandatory provincial patch point in the new directives for hypotensive children that might be in DKA. So a 10-year-old that is hypotensive but you think they might be in DKA, then you have to patch in order to give them fluid. If you receive that order from the base hospital physician, that's online medical control. Another example familiar to Ontario, at least for the next couple of weeks, is that of Orange, where they have 24/7 online medical control through the doc in the box. Perhaps we'll see some changes in how Orange works in the next few weeks. The second method of medical delegation is through medical directives or offline. This is the one that paramedics are intimately familiar with through the base hospital relationship they have. These are blanket instructions from physicians that pertain to any patient who meets a certain criteria and certain circumstances. These must be written in advance and signed off by the physician. Medical directives are used to ensure that healthcare can be delivered without a physician's direct assessment of the patient or direct supervision. They're really meant to encompass as many plausible situations and still be safe, but there's no way medical directives or offline medical control can be all-inclusive. If we tried to make all-inclusive medical directives, they'd be endless, they'd be impossible to train on, and impossible to perform quality assurance on those medical directives. This is the essence of offline medical control. So for those paramedics out there that love to come up with the what-if statements, there will always be lots of these because we can't create medical directives that will meet every what-if statement. An example of an offline medical directive for nurses is ordering an x-ray like we suggested in the one case, or a nurse giving aspirin to a chest pain patient with suspected cardiac ischemia, very similar to primary and advanced care paramedics. So if you were a nurse at London Health Sciences Centre working in the emergency room, then you would be expected to be trained on the medical directives listed on that slide. This actually is a clip or a screen capture from the London Health Sciences Centre website, which lists all the medical directives emergency nurses are expected to know. Within each of those medical directives, there'll be some prose or text which outlines the circumstances of the medical directive, and then a table which outlines the investigations and management that the nurses can do under that medical directive. So what about paramedics? As you're likely all aware, the Ontario Ambulance Act, through Schedules 1, 2, and 3, outlines a list of controlled acts that may be performed by primary, advanced, and critical care paramedics. A paramedic that is trained only to perform Schedule 1 acts can only perform Schedule 1 acts, but can be trained to the level above for certain elements of the schedule above that. There is really no independent scope of practice for paramedics when it comes to the Delegated Health Professionals Act because there's no regulatory college. A little bit later in the webinar, we'll get into the gray or muddy area that surrounds how a college performs quality assurance versus how quality assurance is performed by a base hospital or within a hospital such as London Health Sciences Centre for the medical directives that take place there every day. So the primary and advanced care paramedics are well aware of their own scope of practice that's listed on the slide that you see in front of you. This slide outlines the scope of practice for critical care paramedics. Again, all these skills are delegated to the critical care paramedics. What about the scope of practice for nurses? So we had listed the 3 regulated acts that nurses are allowed to perform independently in some circumstances. If you go to the College of Nurses of Ontario website, which actually performs a lot of the quality assurance for nursing practice, they describe the nursing scope of practice through the following statement. The practice of nursing is the promotion of health and the assessment of, the provision of, care for, and the treatment of health conditions by supportive, preventative, therapeutic, palliative, and rehabilitative means in order to attain or maintain optimal function. This statement, in my mind, is very general, and it allows nurses to practice in the hundreds of different areas that they practice in. If you can imagine, it's very different being a nurse in a family doctor's office, in a remote nursing station up north, on the cardiology ward, in the emergency department, or in the palliative care ward. So this statement encompasses all those things that nurses do once they are a member of the College of Nurses of Ontario. I'm going to pass the presentation back to Samir, presuming he hasn't gone swimming, given it's 30 degrees Celsius after right now.
Can't complain. Got here right in time for summer. So thanks, Adam. Next we'll be going through some more advanced cases in delegation. So here is example case number 5, and this one will be open for a poll. EMS is called for medical backup to a house fire, pretty frequent occurrence. After the fire is over, a firefighter emerges from the home, very warm, diaphoretic, and tachycardic and lightheaded. You take his vitals, but he does have normal blood pressure and temperature. You determine that the patient can probably benefit from some IV fluids from being in the house. So as an IV certified paramedic, you should do which of the following. A, patch to the base hospital for an order and transport. B, give a bolus of normal saline and document the procedure and rationale and then transport. C, do nothing and transport. Or D, leave the firefighter with some Gatorade. So we'll just give everyone a second there to answer. Okay, so we have the majority of people who would patch to the base hospital for an order and transport, and then we have some scattered answers for the other 3. Well, in this case, this is an example of a paramedic doing something that's still within their scope of practice, but it's beyond their medical directives. It does happen to be a safe therapy, but once again, it's beyond your medical directives. The best answer in this case would be A, patch to the base hospital for an order and transport, but C would also be a defendable answer, but A, once again, is the best one. So now moving on to something a little bit more complicated, we have example case number 6. We have an ACP crew who is responding to a call of a 35-year-old male, a large male, 275 pounds, who has a history of epilepsy and is currently seizing. You quickly establish an IV and administer midazolam 2.5 milligrams times 2 with no effect. Now, assuming the patient's blood pressure is normal, as an ACP, you should do which of the following. A, patch to the base hospital for an order for more IV midazolam. B, give another dose of midazolam and document the procedure and rationale. C, initiate transport with no further medications. Or D, administer additional midazolam via IM injection. So once again, we'll give everyone a second here. Okay, so we have 70% of people who say they would patch to the base hospital for an order for more IV midazolam. We have some people who said they would do B or C. The correct answer in this is A, patch to the base hospital for an order for more IV midazolam. So this is an example, once again, of something that's within your scope of practice, but goes beyond your medical directives. The C is your medical directive says you have up to 2 doses of midazolam to give, so you've already given your 2 here. So there's the potential for harm with all the side effects of benzodiazepines, decreased blood pressure, respiratory rate being the big ones. There's a potential to cause harm for the patient. So patching to the base hospital would definitely be your best case scenario here. Going on to case number 7, we have an ACP crew once again in response to a call for a 25-year-old female who is complaining of palpitations, chest tightness, and shortness of breath. She looks diaphoretic and is speaking in 3-word sentences, and her vital signs are there as follows. Notably, her heart rate is 150 and her blood pressure is 75/40. Her electrocardiogram demonstrates a regular narrow complex tachycardia, which is probably SVT. So in this case, as an ACP, you would like to cardiovert this patient, so you would do which of the following? A, cardiovert the patient without sedation and then patch and document afterwards. B, cardiovert the patient using midaz and fentanyl for sedation and then document your rationale on the ACR afterwards. C, patch to the base hospital to ask for orders for sedation so that you may proceed with cardioversion. Or D, transport the patient to hospital in SVT using supportive management. We'll give you guys a second to answer that. So we have the majority of people here selecting C, which is the correct answer, patch to the base hospital to ask for orders for sedation to cardiovert. So this case is an example of something where harm would be done if the paramedics in this case proceeded with sedation. This patient's already hypotensive and showing signs of heart failure from their tachycardia. So giving them midaz and fentanyl would not necessarily be the best choice. So again, C is the right answer, patch to base hospital to ask. All right, going on to CPSO guidelines on delegation. So where does the idea of delegation come from? Well, the CPSO has a great guideline that you can find online, and I'm going to go through some of the major points that the CPSO states should be present if a physician is delegating an act to another healthcare professional. So number 1, and Adam touched on this earlier, is the doctor-patient relationship. This act, the delegating act, remains strictly the responsibility of the physician who authorized it, regardless of who they're delegating it to. So this delegation may occur in the absence of a physician when the timely delivery of necessary treatment is required. So usually this act takes place after the physician has met the patient and provides orders for the next healthcare member to provide. So for example, putting in an IV and maybe drawing some labs for a nurse in the emergency department. And like I said, this can also occur in advance of a physician-patient relationship if it's assumed that the physician will meet the patient shortly after the test has been performed. So the example here would be the nurse is doing an x-ray of an ankle before the physician assesses the patient. Now, the use of medical directives to authorize performance of a controlled act in advance of establishing a physician-patient relationship is really intended to capture only those situations where it's in the patient's best interests. And this is really what it is for you guys. Following the best evidence that's available, your medical directives are all intended to provide crucial out-of-hospital therapy that would otherwise save the patient's morbidity or mortality in the long run. Specific examples where the college has identified appropriate circumstances in which to delegate in the absence of a physician relationship exist. And one example would be the provision of care by paramedics under the direct control of base hospital physicians. So once again, a doctor-patient relationship is necessary. Going on to point number 2, physicians are only to delegate those acts that form part of their regular practice. The Regulated Health Professions Act requires physicians to confine medical practice to areas in which he or she is suitably trained. So a physician must not delegate performance of an act that he or she themselves is not competent to perform personally and which doesn't form part of his or her regular practice and daily competency. So for example, this is why all your SWORB region docs are practicing emergency physicians. You have to be competent doing the procedures yourself in order to tell someone else to do it as well. Going on to point number 3, we have to identify the individual performing the act and be aware of his or her skills. So the physician should be satisfied that the individual to who he or she is delegating the act has the appropriate knowledge, skill, and judgment to perform such a delegated act. So a physician cannot delegate an act where there's a question as to the knowledge, skill, or judgment of the person performing it. Now, Adam will go on to this further when he gets into deactivation and decertification, but this is where those ideas come from. Base hospitals ensure adequate knowledge and skills to their delegatees, I guess, which is you guys, through activities like yearly research, chart audits, and the education like rounds you're listening to right now. When the individual to whom the act is being delegated is a member of a regulated health profession, the physician should ensure that the delegation conforms to the regulations of that health profession. So for example, a physician can't ask a nurse to perform something that isn't within her scope of practice. So that's the easy way to say it there. Next, number 4, we must establish the process for delegation, that education, ensuring maintenance of competence, and lastly, providing appropriate supports. And points under here that are important to highlight. Now, the physician should satisfy him or herself that the delegation is in the best interests of the patient. And so at the end of the day, you can't compromise patient care by delegating a medical act. The physician must also identify the risk in delegating the act. So, we as physicians must analyze the potential for harm that could come from delegating an act, and we must ensure that the risk-benefit profile is in the patient's favor. We must also perform quality assurance and ensure there's ongoing monitoring and evaluation of the delegation, and this must occur in regular, objective intervals. Lastly, we must ensure appropriate resources and equipment are available and that there is written documentation about the delegation process. Number 5, we must ensure that delegation occurs with the informed consent of the patient when feasible, and that's why some of your medical directives will have patient consent in there, mostly at the beginning of the directives. And then lastly, number 6, we must ensure proper supervision of the delegation, and this has to do with accountability and responsibility for the act that's been delegated, and we must provide the appropriate level of supervision. So if it's the physician delegating the controlled acts, must provide the supervision and ensure that the act is being performed properly and safely, routinely. Now, Adam will go into base hospitals, but base hospitals have to provide quality assurance as per the CPSO and the Regulated Health Professionals Act. This isn't something that we just kind of made up as we went along. The base hospital structure, the way it's formed, allows paramedics to do their jobs as you currently do them through the process of delegation. And now I'll pass it back to Adam.
Thanks, Samir. And so there's really no way that the group of 4 physicians at Southwestern Ontario Region-Based Hospital could delegate to 1,300 paramedics without a structure of something similar to the base hospital. And the base hospital, like it or not, tends to function quite well to allow us to meet all of the requirements that the college lays out for us to delegate or do offline medical control or delegation for the medical directives. So that's where all the functions such as creation, revision of protocols, the audits of calls, action based on those audits, the yearly recertification, whether that's education or testing, and the ongoing CME comes into place. It essentially fulfills the requirements that the docs need to meet to delegate to the 1,300 paramedics of Southwestern Ontario. It's not a union, so I've heard people compare base hospital to a union of sorts, such as your union, or the Ontario Medical Association really isn't a union, but that's our professional association that helps defend physicians. It would be more comparable to a college, such as the College of Nurses of Ontario or the College of Physicians of Ontario, the College of Physicians and Surgeons of Ontario, that ensures high-quality care and protects the public. So if you wanted to compare and contrast how quality assurance is performed for regulated health acts for paramedics versus nurses, you could look at the following table that Samir and I created. So for paramedics, quality assurance on regulated health profession acts, it's quality assurance of professional standards by base hospital. The audits, which are if there's any errors or variations from directives identified, are divided into minor, major, critical errors, and then the remediation or reevaluation performed, if necessary, through deactivation, reactivation. If you were a nurse, you would have quality assurance in the hospital through a nursing professional practice committee. So as an emerge doc, I delegate to the nurses in the London Health Sciences Emergency Department through the directives we reviewed earlier, but I am reassured by the Nursing Professional Practice Committee that they audit the nurses following or adherence to these directives that's run by London Health Sciences Centre or the hospital itself. So in essence, the Nursing Professional Practice Committee is functioning as a base hospital program if you were trying to compare that. At least in London in the emergency departments, the charge nurses actually audit every chart of each patient and look for the medical directives that were applied and make sure they were applied appropriately, and if there wasn't a medical directive applied, should there have been one applied. That's very different from the College of Nurses, which also audits a nurse's practice, and if the Nursing Professional Practice Committee within a hospital or a specific charge nurse had concerns about a nurse's practice, they would carry that complaint or concern forward to the College of Nurses of Ontario. So there is a movement afoot to create a College of Paramedics, and there are obviously positive and negative things about doing this. If you look at the current slide, that's just a web clip or a screenshot from the College of Nurses of Ontario website. And any patient, peer, colleague, doc, nurse, paramedic can go to this website and lodge a complaint about the practice of a nurse. Similarly, the College of Physicians and Surgeons has a similar online form and process. I can speak from personal experience that you can have a seemingly minimal interaction with a patient such as what I had at the Urgent Care Centre in London. The patient leaves the department and within 3 minutes has lodged a complaint about the care that I provided. At the end of the day, after I had to write 3 letters and spend numerous hours on the complaint, it was thought to be a sort of a frivolous complaint and nothing was made of it. But it turned out to be quite an ordeal for me to go through to have the college looking at me. So that, to me, would be the process you could compare in your mind to the base hospital process of deactivation or the audit process that you have to go through. So what about when you have a physician on scene? We're going to go to another case example, or case example 8. You have a PCP crew that's IV certified in a long offload delay with a patient complaining of chest pain. The doctor asks the medic to initiate an intravenous and draw bloods from that intravenous prior to hooking it up to the saline. The doc's reasoning for this is to speed up patient care. Dave will put up the poll so that you can see what your potential options are, but the first is to do as you're instructed. It can't be that hard anyway. B is to ask for instructions and abide. C is to inform the MD that it's beyond your scope of practice and still abide. Or D, inform the MD that it's beyond your scope of practice and refuse. I think for the next webinar we need to download some Jeopardy music. Okay, so the poll results are up there, and everyone was correct that it's beyond your scope of practice to draw bloods. Interesting, all of these cases either come from base hospital audits or personal experiences that Dr. Llewell and I have had in the emergency department and overhearing conversations. Example case number 9. So you're called to a family doctor's office to assess a patient that's having chest pain. The patient has a fever at 38.6, a heart rate of 55, a rest rate of 18, a blood pressure of 89 on 48, and oxygen saturations of 98% on room air. The family doctor asks you to administer nitroglycerin to stop this patient's cardiac ischemia. you should A, patch to the base hospital physician for advice, B, ask the MD on scene to take responsibility for care of the patient and accompany the patient to the hospital, C, have the base hospital physician speak to the MD on scene, D, comply with the order as they have more medical training and knowledge, or E, A, B, or C. Great, so if you see the answers on the screen there, A, B, or C was the best answer. Obviously that means that A, B, and C were all somewhat correct. So great job there, everybody. And case number 10, which is the last case, I believe. So you do end up giving nitroglycerin to the patient in case number 9, but the doctor states he or she will follow the ambulance in his or her personal car. He orders further nitro every 5 minutes while the patient is having chest pain. You should A, patch the base hospital doc for further advice, B, transport but give no further nitro, C, ask the MD on scene to accompany the ambulance to administer nitro, D, transport and comply, or E, A, B, and C. Great job, everybody. Very similarly, all 3 of A, B, and C were options there, so the best answer would have been answer E. There was a question about case 9 that came through on the chat box, and what if the doctor just asked you to start a line? Sorry, that was not case 9, that was case 8, and not draw bloods. And so in that scenario, a PCP that's IV certified or an ACP medic, that would be within your scope of practice, and that would be an example of online delegation or online medical control, so that wouldn't be a problem. So what about, how do you summarize the physician on scene? So really you have 3 options when there's a physician on scene. You can advise or assist with the care that follows your medical directive. Give the physician 3 options. The first is to ask them to advise or assist with care that follows your medical directives. So for example, you could ask the physician to perform compressions in a cardiac arrest, or you could ask them to perform BBM in a cardiac arrest. You can ask them to consult with the base hospital physician to offer advice, because theoretically and in most scenarios, the base hospital physician that you can get on the phone would have more knowledge of your scope of practice and pre-hospital care than a family doctor, depending on the individual family doctor and the individual base hospital physician. And if the care that is needed by the assessment of the doc is beyond your scope of practice, the doc that's on scene must assume complete responsibility and must be expected to accompany the patient to the hospital. The medic can assist that doc in providing care within their scope of practice. Okay, so what about deactivation and decertification? This is sort of the folklore or myth that travels throughout medics, that we hear about all the stories of how base hospital is going to come in and deactivate large numbers of paramedics. And my goal in this presentation is sort of to debunk that myth and to defend the process that we follow in base hospital, and that it's a reasonable enactment of the Ontario legislation that surrounds delegation of medical acts. So in terms of deactivation, you receive a phone call from a base hospital physician or professional standards person that you've been deactivated. This means that A, you'll never be able to work again as a paramedic. B, you must have made numerous errors in the last month. C, you made a serious variation of protocol compromising patient safety. Or D, I need to drastically change my approach to patient care. Now, we're not taking a poll on that question. I'm going to let you think about that and go through the next couple slides. So under certain circumstances, deactivation is necessary to ensure safety of the public when care provided by a paramedic is under question. So this goes back to the quality assurance that we must provide in order to delegate regulated health acts. Any clinical-based mistake, the principle here is that any clinical-based mistake can be remediated, either through education or other processes, and that's why we have those processes in place. It may be specific to the procedure or directive that the error took place on, or it might encompass a couple of different directives or areas of knowledge. The goal of the base hospital physician is always to have the paramedic return to work in a safe manner as soon as possible. Base hospital physicians are forced to do this under rare and usually unusual circumstances because we need to defend our action in the future potentially. One point that we've been criticized for in the past was very brief deactivations, and in fact we try and make our deactivations as brief as possible in order to minimize the financial impact on a paramedic, recognizing that your job is your work, and most paramedics, if not all paramedics, are very good at what they do, and we just need to ensure the public safety. So whether it's a 12-hour deactivation or a 3-day deactivation, most of the time we reactivate as quickly as possible to ensure you can be back to work and not lose any money or very little money. So what about decertification? You receive your second deactivation notice in 6 months from base hospital or professional standards, and your coworker tells you that you may be decertified. So there's a lot of myth and folklore that surrounds decertification as well. Decertification usually depends on A, making a single lethal error, B, making multiple serious errors, C, not following medical directives, D, losing trust of the medical directors, or E, B, C, and D. Decertification is an extremely rare occurrence. It's usually dependent on the base hospital physician losing trust of a particular paramedic to perform delegated acts in a safe manner despite remediation and repeated pattern of not following medical directives. So the paramedic or the base hospital in Southwestern Ontario has been involved in 3 different cases of reviewing decertification from around the province. And in all of them, there were repeated errors or variations from protocol made by the paramedics and repeated evidence that the paramedic had lied to the base hospital, lied to the physician, and there was irreparable trust between the physicians and the individual paramedic. So it's a lot harder to repair trust than it is to repair factual knowledge. This is where we came up with the idea of our phone-in line or email or direct communication with the physicians if you think you've made a variation from protocol. This lets us know that 1, we can trust you, and 2, even if there's a variation made in the heat of the moment, you actually understand and know the directives. So it goes a long way if we can have an open conversation about a potential error that occurred in advance of the audit process. I'm going to turn it back to you, Samir, for the concluding remarks.
Great, thanks, Adam. So hopefully you guys found this presentation really informative. I know I definitely learned a lot putting this together because it's not really material that is covered in any sort of depth during medical education, that's for sure. So in conclusion, provincial legislation mandates that controlled health acts be restricted to certain healthcare professionals. The CPSO is the organization that outlines the requirements for medical delegation in Ontario. And the base hospital structure and function allows proper delegation of these controlled acts to paramedics, and thus allows you to function out in the public doing your jobs. Going from the specific cases of going beyond your scope of practice, just don't do it. Do not go beyond your scope of practice or beyond the medical directives regardless of a physician's orders. If a physician does perform any acts that are beyond your directives, the physician then assumes control of that patient and must accompany you to the hospital. Lastly, with deactivation and decertification, deactivation is not meant to be a punitive measure, and decertification is extremely rare, reserved for only the most extreme of circumstances. So once again, thank you very much for joining in. If there's any last questions, I'm sure Dave and Steph will be happy to pass those on to us.
I want to pipe in sort of one last time there, Samir. It's Adam again. I think the title of the presentation, or I know the title of the presentation, was Big Brother or Best Friend. And the take-home message that I would like to see people go home with after this webinar is that base hospital represents a relationship between your base hospital physicians or your EMS physicians, Dr. Dukelow, Bradford, EB, and myself, and the individual paramedic that allows us to delegate our scope of practice or our skill set, Regular Health Professions Act, to the individual paramedics. And 99.9% of the time, that goes very well. On occasion, we need to take a look and check practice, but it's not, should not be seen as a big brother relationship. It's simply a relationship that enables delegation in the field that Dr. Dukelow, myself, Bradford, and EB all enjoy, and we love working with the paramedics and think that the base hospital structure enables that relationship to occur on a positive basis almost all the time. There's some references for the presentation, so you can check out the actual websites where the legislation and college documents exist, and we are open for questions and comments. Dr. Llewell or Mike Llewell and Dave Busich have been on the chat room answering questions there, so if anybody has questions they're not comfortable asking via microphone, they can ask in the chat room, or if you have a verbal question, you can put your hand up and Dave will open your mic. We'll give 20 seconds or so to put a hand up if someone wants to, and if not, you can always ask questions by email or over the phone after the presentation. Well, thanks everybody for your time, and thank you for attending today. Have a great weekend, and look forward to seeing you in the department.
Take care, everyone.